Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a case discussion on a very common case that we see in our OPDs, and that is deviated nasal septum. We'll talk about first what is the history of the patient that has presented to us with, and then we'll discuss about the different history points. What does each of the history that we have taken indicate towards? Then we'll talk about what findings that we have in this patient, and we'll come to our diagnosis, and we'll also talk about how will we manage the case. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So this is a 30-year-old female residing in Hyderabad who has presented with a chief complaint of nasal obstruction on both sides since 6 years. Now, moving on to the history of present illness, the patient was apparently asymptomatic 6 years back when she started complaining of nasal obstruction on both sides. Now, this was insidious in onset, more on the right side than the left side, constant and present all the time. Obstruction is partial on both sides. This is aggravated by common cold and partially relieved on using decongestant nasal drops. And this is also associated with reduced sensation of smell on the right side. Now that's all the history that positive history that the patient has given you with. Now negative history is not a column that you actually write in your case sheet when you write down, but I've just mentioned it for you to know that there are some other histories that you also have to take so that you can rule out a lot of differential diagnosis. So the history that we will take over here is there has been no history of mouth breathing, snoring, facial pain, headache, nasal discharge, recurrent episodes of runny or itchy nose, watering of eyes, sneezing, bleeding from nose, post-nasal drip, throat clearing, fever, trauma, and there is also no history of ear or throat complaints. And we'll talk about each one of them in a little bit. Moving on to past history, we do not have any similar complaints in the past. No other history of any systemic disease mentioned here, no history of surgeries, no known drug allergy. There's no family history which is significant here. Treatment history, we have a history of use of nasal decongestant drops. Coming to personal history, sleep is reduced, appetite is normal, non-vegetarian diet, bladder and bowel movements are normal, and there is no addiction history. Okay, so now let's get started with our first point, the chief complaint that our patient has presented with, which is nasal obstruction on both sides. Now, the question that you will be facing over here is, can you give me the differential diagnosis of bilateral nasal obstruction? What could be the possible causes in this particular patient? So, when you answer any such question where you have been asked the causes of any particular condition, you should start from the more common causes and then move on to the less common ones. We usually have a habit in our viva tables to get flustered, and we end up saying the most rarest of condition first and then move on to saying the common condition. So let's try to remember that when we answer a viva question like this. Okay, so first we'll talk about what are the different causes of bilateral nasal obstruction. So we have here DNS. Now, can you tell me in DNS, we usually the deviation is towards one side. What are some conditions in DNS where you can see bilateral nasal obstruction? There are two such cases. One is a DNS where we have a compensatory hypertrophied inferior turbinate on the opposite side. And second is when we have an S-shaped DNS. These are two conditions in DNS where we'll see a bilateral nasal obstruction. Then we have a very common cause, which is the ethmoidal polyp. The other polyp that we know, antrochoanal polyp, typically gives a unilateral nasal obstruction. Then another common cause which we see in children would be adenoid hypertrophy. Then we have a condition which is known as rhinitis medicamentosa. Can you tell me what is rhinitis medicamentosa? So rhinitis medicamentosa is this condition where we are seeing rebound nasal congestion. And this is caused by prolonged use of topical nasal decongestant drops. So our topical nasal decongestant drops, they're supposed to be decongesting the nose. But what you see instead here is actually the opposite of it. On a very prolonged usage of these drugs, it actually leads to rebound nasal congestion. Can you tell me what are some common drugs which leads to this? Some common drugs which will lead to this is oxymetazoline, xylometazoline. These are usually the common decongestant drugs that we usually use. Other than that, it can also come from nafazoline or phenylephrine. And another very important question here is, usually how long after does this develop? When you use these drops for about more than 5 to 7 days of continuous usage and you continue using even beyond it, that's when rhinitis medicamentosa can develop. So why do we need to know this number? This number is important because that's why when you prescribe decongestant drops to your patient, you have to be aware and very conscious and tell them that they should not use for more than 5 to 7 days at a go. So that's what rhinitis medicamentosa is. Coming back to the causes of bilateral nasal obstruction, some other causes would be a case of vasomotor rhinitis or even in case of atrophic rhinitis. Then we have some septal causes like septal hematoma or a case of septal abscess. And another cause could be bilateral choanal atresia. So these are all the causes of bilateral nasal obstruction that we can say when we are asked. Next is, that also brings in the question, can you name some causes of unilateral nasal obstruction? So here we are having obstruction only on one side of the nose. The commonest cause over here would be a case of DNS. Next is a foreign body in nose. This is commonly seen in kids. A lot of kids will present in the OPD with a unilateral nasal obstruction and they'll have a foreign body in the nose. And another typical history in these cases would be a unilateral foul-smelling purulent discharge. Almost always, if a child has come to you with a unilateral foul-smelling nasal discharge case, you should just assume that this is a case of foreign body because that's very, very commonly seen unless you see any other, unless it has been proved otherwise. So this is a common cause of unilateral nasal obstruction. Then we also have case of hypertrophied turbinate on one side. So that is another cause. Then we have AC polyp, antrochoanal polyp, which typically develops on one side. Then it can be a case of synecdoche in a post-surgical case. Then we can see any other nasal masses. There's a lot of nasal masses, benign and malignant as well. Like for example, we have juvenile nasopharyngeal angiofibroma. We have the inverted papilloma. Then we have rhinosporidiosis, even sinonasal malignancy. So these are all causes that will lead to unilateral nasal obstruction. Some less common causes would be cases of rhinolith or even unilateral choanal atresia and even other granulomatous diseases of the nose. These all will lead to unilateral nasal obstruction. Now, I have another question over here, which is, can you name some causes of unilateral nasal obstruction presenting with bleeding? Now, we have to filter out the causes that we just named above. So one of the causes here would be if there is a case of DNS with spur. Now, how does this spur lead to bleed? Now, this spur is basically this very angulated projection. Now, the mucosa over it gets very stretched and that leads to bleeding. Other than this, foreign body case can also present to you with bleeding, even cases of juvenile nasopharyngeal angiofibroma, inverted papilloma. Then a case of rhinosporidiosis can also have bleeding, even sinonasal malignancy. There's also a condition which is known as bleeding polypus of septum, which is basically the hemangioma of septum. These cases also present to you with unilateral nasal obstruction with bleeding. Even granulomatous disorders of the nose are responsible for unilateral nasal obstruction with bleeding. So these are all the causes, the different differential diagnosis of these three cases that we just talked about. Next, let's move on to the next history point. So, you mentioned that the nasal obstruction is constant and present all the time. What does this indicate? That means if it is saying that this is constant, this is probably indicating that probably there is a structural cause of obstruction over here. And it's mentioning that the obstruction is partial on both the side. What this means is no side is completely blocked. There's only a partial blockage over here. Now, could you tell me a case where, in case a patient has come to you with nasal obstruction, the obstruction was initially partial, but it has progressed to lead to a complete obstruction of the nose. In this case, what would you suspect? In this case, we will be suspecting the presence of a nasal mass, and a nasal mass which is constantly growing in size. And depending on the progress of this growth, we can understand whether this is benign or malignant. If this growth is very rapidly progressive, in that case, it is probably a malignant mass. And if it is slowly progressing to lead to complete obstruction, in that case, it is most likely a benign nasal mass. So, this is the importance of this particular point over here. Next is, we have seen that the patient said that the nasal obstruction is partially relieved on using nasal decongestant drops. Now, this means that probably it is getting partially relieved, right? So, probably the obstruction has one component which is a reversible mucosal obstruction that is happening. We have seen that the obstruction is constant. That meant there is definitely some kind of structural obstruction, cause of obstruction over here. But saying here that it is getting partially relieved on using nasal decongestant means possibly there is a small mucosal component over here which is reversible. So therefore, we are coming to the conclusion that there is probably a mixed obstruction here. There is a structural component and there is a mucosal component. Now, say for instance, the patient said that this was not getting relieved by any decongestant. If there was any kind of nasal mass, that would not be relieved by using a decongestant. It would just be a structural cause. So here we are coming to the conclusion that there is a mixed structural as well as mucosal cause of obstruction over here. Next, the patient has said that they have reduced sensation of smell on the right side. Now, we already know that this is a case of DNS, so I'm explaining over here how would this fit into our diagnosis of DNS is when you have deviated nasal obstruction, nasal septum on one side, so one of the side gets completely blocked. So the nasal cavity passage is actually very less. It has been narrowed down. So the air currents that when we breathe through the nose, the air currents pass to reach the olfactory cleft, and that's how the olfactory pathway works, and we are able to smell. But when the passage gets narrowed, the air currents are actually not able to pass and reach the olfactory cleft. So that is why it in cases like these, in unilateral nasal obstruction, or if there is obstruction more on one side, there is also a reduced sensation of smell on that side. So this is what this will indicate. Next, we'll talk about each one of these negative histories that we have taken from our patient. So first is mouth breathing and snoring. Now, in case mouth breathing and snoring was present, what would it indicate? This is very commonly seen in a case of adenoid hypertrophy in children. The very typical chief complaint that they come to you with is mouth breathing and snoring. Mouth breathing and snoring could also probably indicate towards a nasal or a nasopharyngeal mass. Even in a case of DNS, actually also you will be seeing mouth breathing and snoring if the obstruction is very severe. Next is we took the history of facial pain and headache. Now this is very important in a case like this, because DNS can be very commonly accompanied with a case of chronic rhinosinusitis. So you'll have to look out for symptoms that will suggest this. So headache will be a typical symptom of this. So one of the differential diagnoses over here in case facial pain or headache was present is sinusitis. Then we have something which is known as the Sluder's neuralgia. Now can you tell me what is Sluder's neuralgia? Sluder's neuralgia is this typical condition that we see when a septal spur impinges on the middle turbinate, leading to pressure on the anterior ethmoidal nerve. When this nerve gets compressed, it leads to a very neuralgic pain in the lower half of the face. And along with this, we have three other symptoms. We have nasal congestion, we have rhinorrhea, and we have increased lacrimation. And this is what a case of Sluder's neuralgia looks like. So Sluder's neuralgia is basically a neuralgic pain which you are feeling because the spur is impinging on the middle turbinate. This is important over here. The middle turbinate is most commonly implicated over here, and the nerve getting pressed is the anterior ethmoidal nerve. So that is what Sluder's neuralgia is. Next, other causes of facial pain could be a case of trigeminal neuralgia. Maybe it has happened after a history of trauma, migraines, cluster headaches, temporomandibular joint disorders, cervicogenic headache, dental causes like caries tooth, impacted molar can also lead to facial pain, and then we have vacuum headache. Now, can you tell me what is vacuum headache? A vacuum headache is also this facial pain or headache. Here, what is typically happening is a negative pressure develops inside the sinus. Why does this happen? When there is an obstruction to the sinus ostium, the ostium is blocked. This leads to development of negative pressure inside. Why is negative pressure developing? Because when the sinus ostium is getting blocked, because of any reason, maybe there is a DNS, maybe there is a spur, or maybe there is some mucosal edema. So the air inside the sinus, it starts getting absorbed. Now, as the air starts getting absorbed, there is a negative pressure that develops inside the sinus, and then the sinus mucosa gets stretched. And as a result of this, we have a dull, aching kind of pain, facial pain, and that is known as vacuum headache. It is important to remember that this headache happens without any kind of infection. There is no infection over here, and yet you're having a dull, aching kind of facial pain or headache. And this headache is typically in the frontal region. And it can be a low grade to severe kind of headache. There is no fever and there is no purulent discharge. So you can see that this is actually a differential diagnosis in a case that you may be suspecting that probably this is a case of sinusitis, but there is no infection involved over here. This is a case of vacuum headache, and this is a case, this is a differential diagnosis that can be very commonly missed, and a lot of patients can come to you where they're having a very chronic history of headache, but you are not able to find the cause. And in that case, maybe you can think of vacuum headache, because this is a case where we are seeing no infection. This is happening purely because of a negative pressure that is developed inside the sinuses as a result of the ostium getting blocked by any obstructive case like DNS or spur or anything else. So these are the differential diagnosis of facial pain or headache that you should keep in mind when we have a patient who has presented to you with this. Next is, we also took a case of history of nasal discharge. Now, in case the nasal discharge was present, what will we think about? So again, this will be divided into unilateral nasal discharge or a bilateral nasal discharge. In case of unilateral nasal discharge, as I mentioned, the first cause you should think of in case of a child, if they have presented to you with unilateral foul-smelling nasal discharge, would be a foreign body of the nose. Other than this, we'll also see in cases of rhinolith, androguanal polyp, unilateral guanal atresia, rhinosporidiosis, CSF rhinorrhea, and sinonasal malignancies. Whereas some causes of bilateral nasal discharge would be a case of deviated nasal septum, ethmoidal polyp, allergic rhinitis, vasomotor rhinitis, and chronic sinusitis. Next, wrapping up on the negative history, we have taken history of recurrent episodes of allergic symptoms. This is primarily to rule out allergic rhinitis and vasomotor rhinitis. Like, we'll have symptoms like running or itching nose, watering of eyes, sneezing, even itching of the palate. These are all features that you'll see in case of allergic rhinitis. Next, we took a history of bleeding from the nose. If there is a septal spur, and then in that case we can also see a recurrent history of epistaxis that the patient will come to you with. Next, if there was any bleeding diastasis related nasal bleed, or if there is any malignant mass. Then a history of postnasal drip or throat clearing. This is typically helping us in ruling out chronic rhinosinusitis or any other nasopharyngeal pathology. There was also no history of fever. In case fever was present, we could have thought of some kind of acute infection, maybe acute rhinosinusitis or any acute infective exacerbation, or a case of septal abscess or any other case of systemic infective pathology. Then we also took a history of trauma. It is important to take the history of trauma because one of the etiologies behind a deviated nasal septum, if you had to understand when this happened, could be a history of trauma previously in their life. That could be the cause for DNS. Or also we took history of ear or throat complaints. Now, why is that important? When you're in a case of deviated nasal septum, sometimes your eustachian tube can actually end up getting blocked. So when there's eustachian tube dysfunction, a patient can come to you with otitis media with effusion. So they may not come to you with nasal obstruction, but rather they can present to you with otitis media with effusion. When such a case presents to you with, you should not just look at the ear, but you should do a complete ENT examination to see if there is any other pathology in different places. So when you check the nose in these cases, often you'll see a DNS and you'll see, okay, maybe that's what's causing the eustachian tube dysfunction leading to OME. So in this case, our treatment would have to be directed towards the root cause over here, which is the DNS, rather than the ear itself. So that's why we should take a history of ear and throat complaints as well when we find a nose case, so that you're able to connect all of them. We should look at it at a more holistic view rather than just like, oh, this is just a ear problem and let's just solve it and let's not look at the nose. So that's why you should take a history of ear as well as throat problems over here. So that's all about our negative histories. Next, let's move on to the different past histories that we have taken. So in the past history, we have asked about if there has been any similar complaints in the past. So basically, we are taking a history where we are searching if there is any recurrence history. So in relation to nasal obstruction, there can be recurrence history in case of ethmoidal polyps and even recurrence of a malignant mass. So when we are taking similar complaints in the past, we are trying to see if there is any kind of recurrence that is happening. Then we have taken a history of diabetes mellitus. Now, why is this important? Now, in diabetes mellitus cases, typically you'll have more fungal infections of the nose. And even if it is a case of uncontrolled diabetes, it can end up being a contraindication to surgery. You would have to control the diabetes before taking the patient up for surgery. Next, hypertension. In hypertensive cases, typically they can have epistaxis. They'll come to you with recurrent epistaxis. We'll have to see whether the patient is hypertensive or not and then control the BP, and most of the times you'll see that the epistaxis has disappeared. Hypertension, if it is uncontrolled, can also end up being a contraindication to surgery. Then we have a history of bronchial asthma. Why have we taken this? Because in bronchial asthma cases, associated nasal allergy is seen. Now, if there is nasal allergy, that means maybe the patient has a history of allergic rhinitis. So that is what it will point towards. So history of allergy is important from the point of view for not just allergic rhinitis, but also a case of ethmoidal polyp. We know that the causative factor behind ethmoidal polyp is a cause of allergy, whereas in antroguanal polyp, the causative factor is a more infective origin rather than allergic origin. If you want to know more differences between antroguanal polyp and ethmoidal polyp, I have a separate video that I'm linking above. You can check it out over there. Next, we took a treatment history as well. This is also important. We found out that there is a history of use of nasal decongestant drops. This can also help you understand maybe if it is a case of rebound nasal congestion, which we just learned about Rhinitis Medicamentosa, when a patient is using the drops for a long time, instead of decongesting the nasal mucosa, the patient actually feels rebound nasal congestion. So this is the importance of taking all of these different histories that we have taken so far. So that completes our history portion right now. Next, let's talk about the clinical examination. What are the findings that we have found in our patient? Now, when you're writing our case sheet, you will have to mention about general examination and systemic examination. But I'll skip it over and go directly to the positive findings that we have found. So, coming to nose examination, facial symmetry is present. Skin is normal. External osteocartilaginous framework is normal on inspection and palpation. Bilateral ala, columella, and both the vestibule is normal. Now, on anterior rhinoscopy, we have seen that the septum is deviated to the right. The nasal mucosa is pinkish in color. The floor is normal on both sides. The lateral wall on the right side, we are able to see a normal inferior turbinate, and middle turbinate is not visualized. On the left side, we see a hypertrophied inferior turbinate, and the middle turbinate is not visualized. And nasal cavity is narrowed on both sides. And you have to add a diagram of what you see, something like this. So in this case, we have seen a C-shaped deviated septum to the right side, and you have seen a inferior turbinate hypertrophy on the left side. So this is our finding on anterior rhinoscopy. Posterior rhinoscopy has been normal. Paranasal sinuses are all non-tender. And on the functional tests of the nose, when we perform the Caudel's test, there is no improvement on both sides. On performing the cold spatula test, there is decreased misting on both sides. Cotton wool test also showed reduced movement on both sides. Smell was absent on the right side, and on the left side it was present. And all other examination was normal. So that is what our findings in our case has been so far. So now let's go on to discuss each one of them. So starting with our anterior rhinoscopy. So we saw all our findings on anterior rhinoscopy. So what is anterior rhinoscopy? This is a question you'll typically be asked. So anterior rhinoscopy is an examination of the anterior nares and the nasal cavity using a nasal speculum. And the speculum that we usually use over here is a Thudicum's nasal speculum. Now let's look at Thudicum's nasal speculum. Now this is again a very common, typically favorite question of examiners. They'll just give you a Thudicum's nasal speculum and tell you to show me how are you going to hold it and how are you going to use it. So in that case, you have to take the Thudicum speculum. Let's look at the images over here. You'll hold the speculum at the junction of the two prongs. So these are the two prongs of the speculum. You'll hold it at the junction of the two prongs with the help of your index finger and your thumb on the left hand. So do not pick it up on your right hand. So that's a typical no, because you'll have to use other instruments from the right hand. Typically, Thudicum's nasal speculum is held on the left hand. Now, it is important to remember here, these are the blades that you're seeing here. The blades have to face towards the patient. So you have held it in your left hand in between in your index finger and the thumb, and the blades would be facing towards the patient. Now, this spring action, this speculum has a spring action that you have to control with the help of your ring finger and your middle finger. With the help of this, you'll control the spring action. So you first close the blades gently, and then you introduce the speculum into the nose of the patient with the blades closed, and then slowly, gently open it up by releasing the spring action. That's how you will be using Thudicum's nasal speculum. And this is very, very important on your viva tables, because your examiner, like at least the examiner I had when I appeared for my exams, he had asked me this question, and this is very, very common. And you end up fumbling in that moment. You end up holding it with your right hand, or you end up facing the blades towards yourself, or you hold it with the wrong finger. So this is something that you have to know, practice it beforehand appearing for your exam. Next, with the help of Thudicum's nasal speculum, we are performing anterior rhinoscopy. So that brings us to the next question, which is what are the different structures that you will be seeing on anterior rhinoscopy? So first we will look at this is the view current that you will be seeing when you do anterior rhinoscopy. The first thing that you will be looking at is the nasal mucosa of the patient. Next, we'll look at the floor of the patient. This is the floor of the patient, of the nasal cavity. Next, we will look at the septum. So we'll look at septum on both the sides. Next, we will look at the lateral wall. These are the lateral walls. And in the lateral wall, we will look at the anterior end of the inferior turbinate and the middle turbinate. So this is the middle turbinate and this is the inferior turbinate. So we'll look at the anterior end of it and we'll also look at the meatus. So this is the middle meatus and this here is the inferior meatus. So this is what we'll see on the lateral wall. And then we'll also look at the nasal cavity. Please do not mention that you can also see the roof of the nasal cavity over here, because no, you cannot see the roof of the nasal cavity by doing anterior rhinoscopy. So this is a no. This is not a structure that you will be seeing on performing anterior rhinoscopy. So these are the 5 things that you will be seeing when you perform anterior rhinoscopy. Now let's try to discuss what all that you should be looking out when you're looking at each one of this. So first we are looking at the nasal septum. So we will first see what is the color of the nasal mucosa, not septum. So for nasal mucosa, the things that you should be looking out for is color, edema, dryness, if there is any crust formation or not, if there is any congestion that you are seeing or not. Coming to the color of the nasal mucosa, the things that you should be looking out for, in a normal case, usually it will be very pinkish in color. Whereas if it is a bright red, in that case it will suggest an acute inflammation. If it is a little pinkish white in color, in that case it will suggest anemia of the patient. If it is a pale white color will indicate more towards allergy. I mentioned about crusts. If you see a lot of crusts, a lot of greenish, blackish crusts and discharge, that can indicate towards atrophic rhinitis. So these are all findings that you'll see, that you'll be inferring just by looking at the nasal mucosa. Next, we'll look at the floor of the nose. What are the things that we are looking out over here? We'll look at if there is any defects that you're noticing, if there is any kind of swellings that you're noticing, or often times you'll find foreign body in the floor of the nose. So first of all, let's try to understand what does a normal floor look like. A normal floor will look like a concave tunnel kind of a thing. When I mention about defects, the defects that we'll look out for, if there is any cleft palate or a fistula. In case of swellings, if there is a dental cyst, that can lead to a swelling in the floor of the nasal cavity. And in case of any foreign bodies, we'll also look out for this. And along with the foreign body, sometimes you'll also find discharge around it. So these are all things that you'll be looking out for when you are seeing the floor of the nose. Next is the nasal septum. Now, the first thing that you will be noticing is the location of the septum. In most cases, the septum is never typically a straight line, like in the midline. There will be very mild deviations in most people. So we'll look out for any deviations, if there is any gross deviations that we are seeing or not. If there is any spur coming from the septum, we'll talk about spur in a little bit. If you're noticing any ulcer, or any kind of perforation, or any kind of swellings like you could see a septal hematoma case or a septal abscess case. These are all things that you need to look out for. In case of deviation, we can also have to look out if there is look out for any kind of caudal deviations. We'll talk about caudal deviations in a little bit, and we'll also talk about what is a spur. That is a typical viva question that you are asked. So these are all the things that we look out for in case of nasal septum. Next, we'll look at the lateral wall. In the lateral wall, now we know from the lateral wall anatomy of the nose. If you want to see more on that, I have a separate video on this. I'm linking it above. You can check it out. In lateral wall of the nose, we have 3 turbinates and 3 meatuses, right? We have the superior, we also have the supreme turbinate, but leaving that aside, we have the superior, middle, and inferior turbinate and their meatuses. But we are not going to be able to see all of them on anterior rhinoscopy. So that's something you should remember when you're asked what are the structures that you're seeing on anterior rhinoscopy. We'll only be seeing the anterior end of the inferior turbinate and the middle turbinate and their respective meatuses. In these things, what should we look out for? First of all, we should look at the mucosa. We'll look at the size of the turbinates. Typically, we may end up seeing a hypertrophy turbinate like we have in our case. We'll see for the presence of any kind of crusts. We'll also look out for any discharges. Typically, in cases of acute sinusitis, we'll see mucopurulent discharge, for instance. So that's what we should be looking out for. A lot of the sinuses drain into the middle meatus. So in the middle meatus area, you may end up seeing these mucopurulent discharge that will be directing you towards sinusitis. And we can also see if there is any kind of growth or any kind of nasal mass coming from this area. So these are all things that we should remember. In terms of looking at the size, we have talked about hypertrophied inferior turbinate, but there can also be the other end of the spectrum, which is an atrophic turbinate. And if you see atrophic turbinates, that will point towards atrophic rhinitis. So these are some things that you should be remembering when we are looking at the lateral wall of the nose. Last of all, we are looking at the nasal cavity. Now, when we are looking at the nasal cavity, we will look for what is the patency of the nasal cavity. Are the nasal cavities both normally it should be both cavities should be ideally equal. So we'll try to see if any side is narrowed or it is widened. In case of wide nasal cavity, where do you see wide nasal cavity? We will be seeing wide nasal cavity in a case of atrophic rhinitis typically. Even in a case of gross deviation of septum to one side, we will see a wide nasal cavity. Now, a question here would be, what is a wide nasal cavity? A wide nasal cavity is one where you are able to view the post-nasal space. That's when you know that this is a wide nasal cavity. So other than the wide nasal cavity, we should also look out if there is any growth in the nasal cavity, if there is a foreign body or maggots or anything. So these are all the different structures that you would be seeing on your anterior rhinoscopy, and when you're asked this question, you should be able to list them down just like I said over here. And you have to remember, in lateral wall, we will only be seeing the anterior end of the middle and inferior turbinates only and just their meatuses. So we were talking about when we look at the septum, when we are looking at the nasal septum and anterior rhinoscopy, we should be looking out for perforation, any swelling like hematoma or abscess. So a common question asked over here is, can you name the different causes of septal perforation? So if you look at the image over here, this is what a septal perforation looks like. You can see a through and through perforation, and you're able to see the opposite side lateral wall over here through this perforation. So the different causes of septal perforation over here, there can be iatrogenic causes. Iatrogenic meaning something that we have caused. For example, as a result of doing submucosal resection. I'll talk about how that happens later in the video. Even in case of nasal cauterization, in that case also it can lead to the development of septal perforation. Then we have traumatic causes. Traumatic causes, like if there's a lot of history of digital trauma like nose picking, or in cases of nasal trauma if in some kind of accident. Then we have infective causes. Infective causes can involve cases like TB, with tuberculosis, leprosy, syphilis, even in case of septal abscess. Then we have inflammatory causes, which is mostly some granulomatous conditions like Wegener's disease, or Wegener's granulomatosis, or we have sarcoidosis. These cases also we'll see septal perforation. Then we have some drugs and chemicals that can cause this. For example, a typical MCQ or a viva question over here is a cocaine abuse case, we will be seeing septal perforation. Then even in case of chronic use of topical decongestants, you can see septal perforation. And some industrial chemicals which can lead to septal perforation is when you have exposure to chromium and arsenic. These are some important tidbits to remember about this. And lastly, there can be neoplastic causes, like in case of maybe sinonasal malignancy. So these are all the causes of septal perforation. Now, another viva question that I can think of over here is, can you tell me which part of the septum is perforated in each of these three conditions that I have mentioned here? So we know that the septum has a cartilaginous part and a bony part. So in these conditions, if you look at tuberculosis, in tuberculosis, commonly the cartilage is involved. So the cartilaginous part of the septum is involved in tuberculosis. Even in leprosy, it is a cartilaginous part of the septum that is involved here. Whereas in syphilis, more commonly, the bony part of the septum is more commonly involved. So this is a very important question you can remember. This is a viva question that you may be typically asked. Next, okay. Now, this is again a very, very good question to ask over here. So, how will you be differentiating when, let's say on anterior rhinoscopy, you have seen a mass like this. Now, how will you differentiate whether it is a polyp or just a hypertrophied inferior turbinate? Now, they will look slightly differently, and there's also some different ways that you can tell. So, when you're asked this, the first thing you'll say is, first of all, how does it look? So if you look at the polyp over here, it kind of looks like a pale, smooth, glistening kind of mass. It's like reflecting off light. This is what a polyp will look like. Whereas if you look at the inferior turbinate, this is looking like more like a soft pinkish mass, and this will be seen to be arising from the lateral wall. So this is how it will how you'll be able to differentiate just by looking at it. Next is you'll try to do the probe test. So on probe test, you will look for two things. One is sensitivity to touch, and second, whether it is mobile or not. So the polyp will be insensitive to touch because it does not have any nerve endings over here. Whereas the hypertrophied inferior turbinate will be sensitive to touch because of its nerve endings over here. And second is mobility. So when you move around the polyp, you'll see that it's actually mobile, whereas hypertrophied inferior turbinate will not be mobile. So this is your findings on the probe test. Next is we will check whether it shrinks on vasoconstriction or not. So when we add a vasoconstrictor, or for example, let's talk about the nasal decongestant. So if you add the nasal decongestant or any kind of vasoconstrictor, we'll be seeing that the polyp will not shrink on vasoconstriction, whereas the hypertrophied inferior turbinate will definitely shrink on vasoconstriction. So these are the 4 points that you will have to think about when you're asked how will you be able to differentiate whether it's a polyp that you're seeing or not, or if it's a hypertrophied inferior turbinate. Next question. So we have seen in our case over here that we are seeing a case of DNS to the right, and we have seen a left-sided turbinate hypertrophy. Now, how is this turbinate becoming hypertrophied only on the opposite side? Why hasn't it happened on the same side, for example? So the mechanism over here is when we have developed a deviated nasal septum, what has happened here is there are two unequal nasal cavities right now. So in our case, we saw that the deviated nasal septum was towards the right. So the cavity is narrowed on the right side, and the left side, the cavity has become wider. As a result of this concave side, the left side over here is now the wider side. So this is receiving more airflow. The right side is not able to receive as much airflow. Most of the airflow is entering on the left side of the nasal cavity. Because of this increased airflow, it is leading to increased drying and heat lost from the mucosa. Therefore, the need to regulate the airflow and warm and humidify the air, which are all the functions of our nose, this leads to venous sinusoidal engorgement of the inferior turbinate and a mucosal hypertrophy of these turbinates. Sometimes in very long-standing cases, you can even end up seeing bony hypertrophy. So these three mechanisms. One is venous sinusoidal engorgement, second is mucosal hypertrophy, and third is bony hypertrophy. All of these together leads to the development of this compensatory turbinate hypertrophy on the opposite side. And the purpose of this is to reduce this excessive airflow that is happening here, restore the nasal resistance, and improve the air conditioning of the air by warming it and humidifying it. So this is the reason why we see a compensatory turbinate hypertrophy on the opposite side. Next, we'll talk about posterior rhinoscopy. So in our case, posterior rhinoscopy has been normal. Typically in undergraduation, you'll find it very difficult to do posterior rhinoscopy. The patient may end up gagging out most of the times. Even at that point, you should not skip this point. You should definitely mention over here if you have been able to do it or not. If you have not been able to do it, you could just mention to your examiner that you were not able to perform the examination because of the gagging of the patient. So let's talk a little bit about posterior rhinoscopy. This is actually kind of a difficult region, especially for undergraduate students. So let's talk about it. So what is posterior rhinoscopy basically? Here we are basically visualizing the posterior nares or the choana with the help of a mirror. Very important question here is, what is the size of the mirror and what is the name of the mirror? So we use a St. Clair Thompson mirror, and the size of the mirror is about 10 millimeter. When you're performing posterior rhinoscopy with the help of this mirror, one thing that you need to be aware about is the moment you introduce into the oral cavity of the patient, you'll see that the mirror starts fogging. So what are some ways that you can prevent fogging of the mirror? One is you can dip the mirror in warm water before introducing it. You can rub the mirror over the flame of a spirit lamp. You can rub the mirror surface on buccal mucosa and generate heat by friction. You can dip the mirror in defogging solutions like cetrimide. And lastly, I've already mentioned this point. So these are the different ways that you can prevent fogging of the mirror when before you have introduced it into the oral cavity. Now, we have two mirrors in our OPD instrument set. We have the indirect laryngoscopy mirror and the posterior rhinoscopy mirror. You may get confused as to which one is for what. So let's try to understand the differences between these two mirrors. So the indirect laryngoscopy mirror is actually a larger mirror. Usually it has a 10 to 25 millimeter diameter. Whereas the posterior rhinoscopy mirror is smaller and it typically has different sizes from 5 to 10 millimeter diameter. So in children, you use a smaller diameter mirror, and in adults, you use a slightly larger one. And the angle of the mirror is different. If you look at the image over here, this is a very straight mirror and just angled at the edge at the mirror. Whereas in the posterior rhinoscopy mirror, we are able to see this acute angles. There are two bends over here that we can see, and it is typically about 45 to 60 degree angle. And if you look at the length of the shaft also, the indirect laryngoscopy mirror is shorter, and the posterior rhinoscopy mirror, the length of the shaft is much longer. So these are the differences between the indirect laryngoscopy mirror and the posterior rhinoscopy mirror. And when you're asked to pick up, sometimes the examiners can actually confuse you. They'll have all the OPD instruments in front of you, and they'll just tell you, can you pick up the posterior rhinoscopy mirror? And then you see both these mirrors in front of you, and you can actually get confused like, oh shit, I forgot, which one is it? So this is how you'll remember it. Next, let's talk about how are we going to perform posterior rhinoscopy. So first of all, you'll explain to the patient the procedure that you're going to do, because this is going to involve a lot of cooperation from your patient's end. So you have to assure them, you have to tell them exactly what you're going to be doing. After that, we are going to warm the mirror, or all the other different methods that we had to reduce the fogging. Then we'll test the warmth of the mirror on our flexor aspect of the wrist before we put it in the mouth, so that in case it's too hot and we put it in the mouth, and it may end up injuring the patient's oral mucosa. Then we will depress the tongue with the help of a Lux tongue depressor, and we'll slowly pass the mirror behind the soft palate without touching the uvula and the surrounding structures. The moment you touch any of these structures, the patient will start gagging. So it's important that you do not touch any of the structures and slowly go behind the soft palate. And very important instruction that you have to give over here is, you have to ask the patient to breathe through the nose. And as the patient breathes through the nose, this will relax the soft palate and giving you more space in the oropharynx to insert your mirror. So the soft palate ends up moving forward and downward as the patient breathes through the nose. And as you put your mirror in the post-nasal region, you will be able to see the different structures over there. Now, very important over here, if the patient starts to breathe through the mouth, the soft palate will end up elevating and it will end up closing the nasopharynx. And this will obstruct your view. So it is important for you to explain to the patient that they have to breathe through the nose when you're performing the procedure. Next question is, what are the different structures that you will be seeing on posterior rhinoscopy? So we will be seeing your structure of your answer over here should be, there are some structures that I'll be seeing anteriorly, laterally and superiorly. So let's start with the first structure that we'll be seeing. So anteriorly, first, let's look at the image over here. We will be seeing the posterior edge of the nasal septum. This is the first structure that you should identify when you place your mirror. Then we'll be seeing posterior end of the middle and the inferior turbinates. We'll also see posterior end of the superior turbinate. This is the highest landmark that you will be seeing. Then we also have the posterior part of the middle and superior meatus. And anteriorly, when you tilt the mirror a little more anteriorly, we'll be able to see the nasal surface of the uvula and the soft palate. So these are the structures that you can see anteriorly. Then laterally, let's look at the image over here. Laterally, we are going to be able to see the eustachian tube opening on either side with the tubal elevation behind the posterior end of the inferior turbinate. We'll also be seeing the fossa of Rosenmuller, which lies just behind the eustachian tube opening, but this is much more difficult to see compared to the other structures over here. So these are the three things that you will be seeing on the lateral wall. Next, moving on to superiorly, we will be seeing the roof of the nasopharynx. In case of children, you will be able to see adenoids as well. So if a very common case that you see in case of children is a case of adenoid hypertrophy. You'll be able to see adenoid hypertrophy in these cases. And lastly, you'll be seeing the superior part of the posterior pharyngeal wall as well. So these are all the different structures that you will be seeing on performing the posterior rhinoscopy. Next, we checked all the sinuses for tenderness. In our case, we did not find any of the sinus to be tender. So that was our conclusion. So that probably rules out in case of acute sinusitis. But a common question here would be, your examiner will ask you to demonstrate what is the site that you will be checking for each of the sinuses. So let's go through each one of them. So first is the frontal sinus. So for the frontal sinus, we will be checking it. So these are the eyebrows that you're seeing over here. We'll check it below the medial end of the eyebrow, which is the floor of the frontal sinus and superior to the inner canthus. This is the region that we'll see. This is basically the floor of the frontal sinus. Why are we checking here and why are we not checking on the forehead? That's because the floor of the frontal sinus, the bone is actually thinner over here, and this is also the dependent part of the sinus. Now this is where we'll palpate for the frontal sinus tenderness. Next is ethmoid sinus. So ethmoid sinus, we'll check it at the side of the nose medial to the inner canthus. And lastly is the maxillary sinus, which we will be checking in the canine fossa. So this is where you'll be checking for maxillary sinus tenderness. And it is important to remember here is that you cannot palpate the sphenoid sinus. So do not mention sphenoid sinus over here. We can only palpate the frontal sinus, ethmoid sinus, and the maxillary sinus. And even in ethmoid, you're actually palpating the anterior ethmoid sinuses. Posterior ethmoid sinuses are also not palpable. They are located much deeper. So we saw that we have to palpate in the canine fossa region for maxillary sinus. A very favorite question of examiners over here is, they'll ask you what are the boundaries of canine fossa. So the boundaries of canine fossa is, superiorly we have the infraorbital foramen. This is the infraorbital foramen. This is the superior boundary. Inferiorly we have the alveolar ridge. Medially we have the piriform aperture, and laterally we have the canine eminence. So this is the boundary of the canine fossa. And can you tell me what is the clinical importance of canine fossa? Clinical importance is, first of all, as we know already, that we elicit the maxillary tenderness over here. And second, we also used to perform carpal lux surgery through this canine fossa. This is not a surgery we do nowadays as much, but these are the two importance of knowing the boundaries of canine fossa. Next we after the sinus tendernesses, we have moved on to do the functional tests of the nose. Now, when we perform Caudal's test in our case over here, there has been no improvement. This was a negative Caudal's test. Now, before that, we need to know what is Caudal's test and how do you do Caudal's test and what are the interpretation that you get from it. So let's look at the image over here. So Caudal's test is basically any test which is done, not any test, sorry. It is a test that we do to check for any pathology of the internal nasal valve area. So if we look at the image over here, how do we perform this? We pull the cheek laterally away from the midline. At this point, we see if the nasal airway, the nasal obstruction improves on the tested side or not. In case it improves, that means it is a Caudal's test positive. That means it is indicating that we have an abnormality in the nasal valve region. And if this has not improved on pulling the cheek away from the midline, if the nasal obstruction does not improve or the nasal airway does not improve, in that case, this is known as the negative Caudal's test. That means that the obstruction is likely to be due to other causes other than the internal nasal valve. The next question that comes over here is, can you tell me the boundaries of the internal nasal valve? So, internal nasal valve, this region is actually the narrowest part of the nose. So, any obstruction that happens in this area will actually lead to a feeling of very severe obstruction by the patient because this is already a very narrow area. So what are the boundaries that we see over here? So this is an endoscopic image that we can see. So our boundaries is medially we have the septum. Laterally we have the caudal edge of the upper lateral cartilage and the head of the inferior turbinate. Let's look at the image here. This is the caudal edge of the upper lateral cartilage and the head of the inferior turbinate, and below we have the floor of the nasal cavity. So these are the three boundaries of the internal nasal valve, and the importance of this is that this is the narrowest part of the nose. So if there is any obstruction in this area, it will be felt a lot, and you have to correct any obstruction that is present in this region. You have to correct the internal nasal valve area. So now we have completed discussing about the clinical examination, what are the finding that we found, and what are typically the questions that are asked around at this point. So now let's summarize our case. So when you're asked to summarize your case, you basically have to give the most important points both from your history as well as clinical examination to your examiner. So in our case, a 30-year-old female came with a chief complaint of both-sided nasal obstruction for about 6 years. The nasal obstruction is insidious in onset, more on the right side than the left side, constant and present all the time. Obstruction is partial on both sides, aggravated by common cold, and partially relieved on using nasal decongestant drops. This is associated with reduced sensation of smell on the right side. On examination, we found that the septum is deviated to the right with a hypertrophied inferior turbinate on the left side. Nasal mucosa on both sides was pinkish. Nasal cavity is narrowed on both sides. Caudal's test showed no improvement on both sides. Caudal wool test showed reduced movement on both sides, and cold spatula test showed reduced misting on both sides. And smell was absent on the right side. So this is our summary of the patient. Now, what is our provisional diagnosis over here based on all of the things that we have seen so far? So our provisional diagnosis over here is a case of deviated nasal septum to the right with left-sided compensatory hypertrophied inferior turbinate. So that's what our provisional diagnosis is over here, and this is exactly how you should mention And don't just mention that this is a case of DNS. Don't say it like that. You have to specify the deviated nasal septum to which side, and if there is any additional findings like left-sided compensatory hypertrophied inferior turbinate, or if there was any symptoms of rhinosinusitis, you could say acute with chronic rhinosinusitis or acute rhinosinusitis, whatever it is, you have to mention all of these things in your provisional diagnosis. Now, the next question typically asked here is, what are the points in favor of your diagnosis? So let's start right from history. Whenever you're asked this, start from history, then move on to clinical examination. So from our history, we found that our case was of bilateral nasal obstruction. And this bilateral nasal obstruction was constant, aggravated by cold, and it gets partially relieved by nasal decongestant drops. This is the first history that we took. Second, there was a reduced sensation of smell on the right side. And on examination, we found that there was a deviated nasal septum to the right side, and we found a hypertrophied turbinate on the left side. We found that the nasal cavity was narrowed. And when we performed the cotton wool test and cold spatula test, both of that showed reduced misting and reduced movement on both the sides. And Caudel's test was shown to be negative. So all of these things together are pointing to the fact that this is a case of deviated nasal septum to the right with left-sided compensatory hypertrophied inferior turbinate. So now that brings us to some questions related to deviated nasal septum. Now, what are the different types of DNS that you can have? So we can divide this in two ways. One is the DNS can be a cartilaginous type or a bony type, or even both actually. So we know that the nasal septum has a cartilaginous part, which is the septal cartilage over here. And then we have the different bony parts. The two major bones over here are the perpendicular plate of ethmoid and the vomer. So any DNS involving just the cartilage will be a cartilaginous one, and any one involving the bone will be the bony DNS. The second type that we know over here are the different images that we can see. So the first image is showing what a normal septum is looking like. Second is we have a C-shaped deviation. So in cases of C-shaped deviation, typically it's the septum is shaped like a C, and it's mostly deviated towards one side, and the other side most commonly actually ends up with a compensatory hypertrophied inferior turbinate, which we are seeing exactly in our case. So in a C-shaped deviation, typically we end up seeing a gross deviation to one side, and the other side develops a hypertrophied inferior turbinate. Next, we have a S-shaped deviation. Now, in S-shaped deviation, usually the septum gets this particular S-like shaped. So you end up with patient who is complaining of bilateral nasal obstruction because both the nasal cavities gets narrowed over here. So this is typically what a S-shaped deviation will look like. Then we have the caudal deviation or the anterior deviation. I'll talk about this in just a moment. In caudal deviation, typically the caudal edge of the septum is what gets deviated. So this is best seen when you raise the tip of the nose of the patient and look at it. We'll look at an image right after this. Then we have the septal spur. Septal spur is when a spur, what is a spur? Now that is a very important question that you're asked. What is a spur? Spur is this sharp, shelf-like bony projection. It's important to know that it is a bony projection which usually arises from the bony cartilaginous junction of the septum. And this projects laterally into the nasal cavity. So what is a spur? A septal spur is a sharp shelf-like bony projection arising from the bony cartilaginous junction of the nasal septum, projecting laterally into the nasal cavity. That is what a septal spur is, and you can see this is what it looks like. So usually it ends up impinging on the structures of the lateral nasal wall. Lastly, we have septal thickening over here. Now, septal thickening is much less commonly seen, but this can arise as a complication of maybe septal hematoma, where the hematoma gets resolved, but it leads to it leads to septal thickening. So these are the different types of DNS based on the way the septum is deviated. We were talking about caudal dislocation. So this is a very important thing that you need to know here. What is caudal dislocation? So when you raise the tip of the nose of the patient, sometimes you'll see a deviation like this, where the caudal end of the septal cartilage gets displaced from its normal position on the maxillary crest, and it comes to lie on one side of the nasal cavity. This results in an anterior nasal obstruction. So this is what a caudal dislocation looks like. And caudal dislocation is something that you earlier we would have SMR before septoplasty came on, and SMR could not treat the caudal dislocations because of the approach being very different in SMR compared to septoplasty. We'll talk about that at the end when we discuss management. So this is what a caudal dislocation is. And I've already told you what a spur looks like. If you look at the image here, this is what a spur will look like. And the most common place that it arises in is the junction of the vomer and the septal cartilage. Next, we have something which is known as Caudal's classification of DNS. And that is very important, and this is something that you should know. So according to Caudal's classification, we have three types of DNS: simple DNS, obstructed DNS, and impacted DNS. Now, in simple DNS, what we are seeing is a mild deviation of the septum, which does not cause any nasal obstruction. So therefore, we do not need to see any effect of vasoconstriction, and here we do not need any treatment. Then we have the obstructed DNS. Now, in obstructed DNS, we have a more severe deviation where the septum is touching the lateral wall. So we have a patient who is complaining of nasal obstruction. Here, when we try to check effect of vasoconstriction, the obstruction gets relieved using the nasal decongestant, which work by shrinking the turbinates. Here, in terms of treatment, we can use nasal decongestants and surgery only when required. Most of the time, surgery may be required over here. Then we have the third type, which is impacted DNS. Now, impacted DNS, we are seeing a marked angulation of the septum, especially a spur, where the spur lies in contact with the lateral nasal wall. Here, even when you try to use nasal decongestants, you will not get any relief on vasoconstriction. So in this case, surgery becomes essential. It is no longer a choice. You will definitely have to do surgery in these cases. So this is the Caudal's classification of DNS. Now, talking about Caudal, there are a few other things that you need to know related to Caudal in terms of the nose. First one is, what is Caudal's line? This is again a very common viva question asked. So if you look at the image over here, Caudal's line is actually a vertical line that is passing between the nasal process of the frontal bone. So this is the nasal process of frontal bone to the nasal spine of the maxillary crest, which is right over here. This is the maxillary crest and this is the nasal spine. So it is a vertical line passing between these 2 points. And this ends up dividing the septum into an anterior segment and a posterior segment. What is the importance of this? What I was mentioning just a little while back when I was talking about caudal dislocation, where I was telling you that a caudal dislocation cannot be treated by SMR. So here, any deviation that lies anterior to the caudal line, we can treat it only by septoplasty. Whereas any deviation which lies posterior to the caudal's line can be treated either by SMR or by septoplasty. So that is the importance of knowing about the Caudal's lines. Next, another thing related to Caudal is we have the Caudal's area. What are Caudal's areas? So we have 5 areas which was named by Caudal. If you look at the image over here, the first one, area 1, is the nostril. Next is area 2. Area 2 is that of the nasal valve, and we have already discussed nasal valve a little while back. Next is area 3. Area 3 is the area which is lying underneath the bony and cartilaginous vault, and this area is also known as attic. Then we have area 4, which is the anterior part of the nasal cavity, including the heads of the turbinates and the infundibulum. And lastly, we have the area 5, which is the posterior part of the nasal cavity, including the posterior ends of the turbinates. So these are all the Caudal's areas that you need to know. Lastly, there's one more thing that you need to know. What is the instrument that you know that has the name Caudal in it? And that is Caudal's elevator. And Caudal's elevator is very commonly used in septoplasty, SMR, and rhinoplasty. And what is the purpose of it? We elevate the mucoperichondrium from the septal cartilage and the mucoperiosteum from the bony part of the septum using the Caudal's elevator. So that's about the different questions that it can be asked related to deviated nasal septum. Now going into some anatomy questions related to the nasal septum. Now, a very common question is, what are the different parts of nasal septum? Now, it can actually be our response to just say the different parts of nasal septum is the bony part and the cartilaginous part, but that is actually not the complete answer. So if we had to talk about the different parts of nasal septum, we'll divide it into three parts. We have the columellar septum, we have the membranous septum, and then we have the septum proper. This is the right way to give this answer. Now, what is columellar septum? Columellar septum, if you look at the image, this is the columella. So, columellar septum is formed of the columella, which contains the medial crura of the alar cartilages. And they fuse together by fibrous tissue and they're covered on either side by the skin. So if you just were to touch your nose, that the tip of at the tip of your nose, if you hold the lowermost part, the columellar region, that is what you're holding is the columellar septum. Next, we have the membranous septum. So this in the image over here, this is the membranous septum. Now this membranous septum consists of double layer of skin with no bony or cartilaginous support. So this is only a double layer of skin, and this lies between the columella and the caudal border of the septal cartilage. And these two portions, the membranous septum and the columellar septum, these two are freely movable from side to side. Next, now we come to talking about the septum proper. Now, septum proper can be divided into two parts. Here, now you do the division into bony part and the cartilaginous part. So the septum proper can be divided into a bony part and a cartilaginous part. Now, as we know, the cartilaginous part is formed by the septal cartilage. So cartilaginous part is simple. Now, when we look at the bony part, if we look at it, there are two major contributions. First one is the perpendicular plate of the ethmoid, which is forming the upper 1/3 of the nasal septum. And second major part is the vomer bone, which is forming the posterior and inferior part of the nasal septum. Now, other than these two major bony parts, we have a lot of minor contributions as well. Now, let's look at all the contribution. We have the crest of the nasal bones. This part is the crest of the nasal bone. Next, we have the nasal spine of the frontal bone over here. Next, we have the rostrum of the sphenoid. This part over here, you can see this is the rostrum of the sphenoid. Next, we have the crest of the maxilla and the crest of the palatine bone over here. And lastly, we also have the anterior nasal spine of the maxilla over here. So these are all the minor contributions which are contributing to the bony part of the septum. So if I had to recap right now, the different parts of nasal septum are columellar septum, membranous septum, and septum proper. Septum proper in itself can be divided into bony part and cartilaginous part. Cartilaginous part involves the septal cartilage. Bony part has some major contributions and minor contributions. Major contributions are by the perpendicular plate of ethmoid and the vomer. Minor contributions are crest of nasal bone, nasal spine of frontal bone, the rostrum of the sphenoid, crest of maxilla, crest of palatine, and the anterior nasal spine of maxilla. This is the complete answer when you are asked about what are the different parts of nasal septum. Do not jump directly into bony and cartilaginous part because that is what our instinct tells us to do. Next question related to anatomy is, what is the blood supply of nasal septum? Now, there is a very structured way of approaching this, and that way it will also be very easy for you to remember. So, if we broadly look at it, we have supply which is coming from the internal carotid artery system, and then we have supply coming from the external carotid artery system. First, let's talk about the ones coming from internal carotid artery system. So we have two arteries coming from here. One is the anterior ethmoidal artery and the posterior ethmoidal artery. If you look at the image over here, first one is the anterior, and both of them actually, both of these two arteries that we are seeing, they are both branches of ophthalmic artery, and ophthalmic artery is a branch of the internal carotid artery. So basically, internal carotid artery, it gives a branch. Ophthalmic artery gives two branches over here, anterior ethmoid and posterior ethmoid. The anterior ethmoid artery goes and supplies the anterosuperior part of the septum, whereas the posterior ethmoid artery supplies the posterosuperior part of the septum, as you can see in the image over here. Now let's move on to the external carotid artery system. So the external carotid artery system, we have one of the terminal branches of external carotid artery is the maxillary artery. And maxillary artery gives off two branches from its third part of the maxillary artery. We have the spinopalatine artery and we have greater palatine artery. Now, greater palatine not itself is a direct branch of the third part. Greater palatine is actually a branch of descending palatine artery, which comes from the third part of maxillary artery. Now, the spinopalatine artery gives off a posterior septal branch. This branch that you're seeing over here, this is the posterior septal branch, and this supplies the posterior-inferior part of the septum. Then from the greater palatine artery, we get a septal branch again, and which supplies the antero-inferior part of the septum. Here you can see the septal branch of the greater palatine artery. And lastly, we have the facial artery, which is a branch coming from the external carotid artery. This facial branch artery gives off a superior labial artery. And from the superior labial artery, we have the septal branch which comes and supplies this caudal area, caudal septum and the columella. So these are the 5 different arteries which is supplying the nasal septum. Now if we, again I'll recap and say it in a very short manner exactly what you should be saying in your exams. So the blood supply of the nasal septum is derived from both carotid system, the internal carotid artery and external carotid artery. From the internal carotid artery, we get two branches, the anterior ethmoidal artery and the posterior ethmoidal artery. The anterior ethmoidal artery supplies the anterosuperior part, posterior ethmoidal artery supplies the posterosuperior part. Now next, moving on to the external carotid artery system, we have 3 branches coming from here. 2 of them are coming from branches of maxillary artery. So we have the spinopalatine artery, which gives a posterior septal branch to supply the posterior-inferior part of the septum. And then we have the greater palatine artery, which gives off a septal branch to supply the antero-inferior part of the septum. Lastly, we have a branch coming from the facial artery. So the facial artery has a branch which is the superior labial artery, and the superior labial artery gives off a septal branch to supply the caudal septum and the columella. So these are the 5 different arteries supplying the blood supply of the nasal septum. And this table is very, very important for you to remember so that you're able to answer this question. Next question, what is Little's area? The other name that we know from Little's area is actually Kieselbach's plexus. That is also a term that you should be knowing. Now, Little's area is this little vascular area that we see in the antero-inferior part of the septum, nasal septum, just above the vestibule. And this is formed by an anastomosis of different arteries in the nasal septum. Now, just now we studied about 5 arteries that supply the septum. You have very easily to remember the supply of this Little's area. What are the arteries forming this anastomosis over here? Just you have to deduct 1 artery. So 4 arteries from this supplies the Little's area. Only 1 artery does not. Which one is it? It is if you look at the image, the answer is actually quite clear. The posterior ethmoid artery does not form a part of the anastomosis of the Little's area. So if you remove posterior ethmoidal artery, we have the answer over here. Little's area is formed by the anastomosis between anterior ethmoidal artery, the septal branch of superior labial, the septal branch of greater palatine, and the posterior septal branch of sphenopalatine artery. So these are the 4 arteries forming the Little's area. Now, what is the importance, the clinical importance of knowing Little's area? First of all this is the most common site for development of anterior epistaxis. Why so? This is because you can see that there are 4 arteries anastomosing over here. So you can see there is a very rich vascular supply over here. And because the region is located so close to the vestibule, it's also very susceptible to injuries through digital trauma. So you'll see in a lot of children, actually even in adults for that matter, a lot of nose pecking can happen. And nose pecking in this particular area can actually lead to involvement of the Little's area, this anastomotic area, leading to epistaxis. Second reason why this area is important is this is the site of origin of a condition which is the bleeding polypus of septum. Bleeding polypus of septum is basically the hemangioma of the septum. This originates from the Little's area. So this is all about Little's area that you need to know, and the easy way to remember the anastomosis, the different arteries forming the anastomosis over here. Now we move on to discuss how do we manage the case. Now when we are asked this question during our exam, we jump into saying, okay, so this is the treatment that we'll give to our patient. But the examiner has asked you about the management of the case, not just the treatment. You have to remember management always comprises of investigation and treatment. So your answer should be, I will perform some investigations and then I will do these treatments. So you'll always have to talk about the investigations first and then move on to treatment. Both of them together form management of the patient. So first, let's talk about the different investigations that we will be doing. First, we will be doing some routine blood investigations. What are these routine blood investigations? CBC, BT, CT, we'll do RBS, we'll do serology. Within serology, we'll be doing HBS, AG and HIV. Then we'll do urea and creatinine. These are the routine investigations. Second is we'll perform a diagnostic nasal endoscopy of the patient. Now, what is the purpose of doing this diagnostic nasal endoscopy? First of all is we will confirm the extent and type of the septal deviation. We'll see where is the septal deviation exactly, what are the structures it is impinging on. Second, we'll also assess this inferior turbinate hypertrophy that we have seen. And third, we will rule out any case of polyps, any kind of sinus pathology, or any kind of other nasal mass over here. So this is the reason why I'll do diagnostic nasal endoscopy. And the third thing that we'll do is a CT scan of the paranasal sinuses. This CT scan of the paranasal sinuses is usually indicated when the patient has any facial pain or headache, any suspicion of sinus disease is there, or also for surgical planning. So before we talk about the treatment, if we are to do any surgical management in the patient, for surgical planning also we should do a CT scan of the paranasal sinuses. Next, moving on, how are we going to treat the case? So in this case, what we will do is we'll perform a septoplasty and a left inferior turbinate reduction. So we had a DNS to the right and we had a left inferior turbinate hypertrophy. For the DNS, we will be doing septoplasty, and for the left inferior turbinate hypertrophy, we will be doing a left inferior turbinate reduction. Now we'll move on to discussing some questions related to the surgeries over here. So first of all, the question that will come is, what is septoplasty? Now, septoplasty is a conservative surgical procedure to correct a deviated nasal septum by correction of the deviated portions of the septal cartilage and or bone while preserving adequate septal support. So our next question here is, what are the different indications of septoplasty? Now, the indications of septoplasty, we can divide it into two. we can divide it into septal causes and we can divide it into non-septal causes. So first let's talk about the different septal causes. So every case of deviated nasal septum or a DNS that comes to you, you do not just perform septoplasty, because you'll actually see that DNS is very common in most patients. If the DNS is not causing any issue to the patient, then we do not perform septoplasty. But in which cases will we perform septoplasty? First of all is if the patient is complaining of nasal obstruction on one or both sides. So if a DNS is causing nasal obstruction on one or both sides, that's our first indication of septoplasty. Second indication is if there is recurrent epistaxis happening because of the spur. Third indication is headache. Now, headache can be of different types. One is headache because of sinusitis. So, say for instance, in this case, let's see if the osteomeatal complex gets blocked, then the drainage of sinuses will be blocked, as a result of which the patient will have sinusitis. So, one of the reasons of headache in these cases would be sinusitis. Second is Sluder's neuralgia. Now, in Sluder's neuralgia, say let's look at the spur over here. Let's imagine the spur is on the upper part. Now, if this spur is impinging on the middle turbinate, as I had mentioned earlier, it will compress the anterior ethmoidal nerve. Now, if that happens, the patient will have this neuralgic-like pain. So, in Sluder's neuralgia also we'll see headache. Then we have the vacuum headache. We already talked about vacuum headache, where what is happening is because of the sinus ostium getting blocked, the air inside the sinus starts getting absorbed, as a result of which you develop a negative pressure inside the sinus, leading to headache. So these are the different causes of headache, and when there is a DNS causing headache, we also have to do septoplasty. And the fourth septal cause over here would be a case of sleep apnea or a hypoapnea syndrome. So these are the different reasons, septal causes, why you should perform septoplasty. Next, let's move on to discuss the non-septal causes. Now, under the non-septal causes, first is if we have to harvest a cartilage graft from the septal cartilage. Cartilage graft is usually required, for example, in cases of septorhinoplasty or commonly done tympanoplasty or even in laryngotracheal resection. So if we need a septal cartilage for grafting, that will be one of the causes. Second is septoplasty can be done as a part of an operation of septorhinoplasty. It can be actually combined with rhinoplasty. Third is if septoplasty is used as an approach to other surgeries. Septoplasty is done so as to give more access to the endoscope while performing any other surgery. For example, we have endoscopic dacryocysto-rhinostomy. If you are doing an endoscopic dacryocysto-rhinostomy and there is a septal deviation present, you will not be able to approach the area that you want to. So in that case, septoplasty is done. Second is if we are trying to approach the middle meatus or the frontal recess in case of endoscopic sinus surgery and the DNS is obstructing the view. Third is if we want to reach the pituitary fossa. So if you see over here, if we are trying to reach the pituitary fossa and we want to do maybe an endoscopic hypophysectomy. In these cases also, if there is a DNS and it's blocking it, we'll not be able to do it. So these are the different non-septal causes. So if I had to recap, the indications of septoplasty can be divided into two. Septal causes and non-septal causes. In septal causes, we have a DNS causing nasal obstruction, DNS causing recurrent epistaxis, DNS causing headache, and DNS causing sleep apnea. Non-septal causes are, one is if we want to harvest a cartilage graft, second is as a part of septorhinoplasty, and third is as an approach to other surgeries like endoscopic dacryocysto-rhinostomy, as a part of FES, as an approach of FES, and endoscopic hypophysectomy. So these are the different indications of septoplasty that you need to know. Next is, what are the contraindications of septoplasty? So contraindications would be any case of acute infection of the nose or paranasal sinuses. In these cases, we would have to first treat the infection and then perform the surgery. And also cases of uncontrolled diabetes mellitus, hypertension, or any cardiac problem. First, you'll make sure that this is taken care of, and then we move on to do the surgery. And also in cases of uncontrolled bleeding diathesis. Next is, again, a very important question is, what are the different types of septoplasty incisions? So we have three main incisions over here. One is the hemitransfixian incision, which is also what we call as Freer's incision more commonly. And then we have the transfixian incision, and then we have the Killian's incision. So first, let's start with Killian's incision. So if you look at the image here, we are seeing this is the Killian's incision, the blue line over here. So Killian's incision is an incision that you place 5 mm above or cephalid from the caudal border of the septal cartilage. And this incision was typically actually used in SMR. So this is Killian's incision. Second is the hemitransfixian incision or the Freer's incision. So if you look at the image over here, the red line that you're able to see here, this is what the Freer's incision looks like. So Freer's incision is basically this incision that you're making at the caudal edge of the septal cartilage on one side. That is why it's known as hemi. And this is giving you access to the cartilaginous and bony septum while at the same time preserving the columellar support. Now, this hemitransfixian incision can actually be of different types depending on the length of the incision you require. And the length of the incision will depend on what is the access that you require. So, the hemitransfixian incision can be of three types. We have a partial one, we have a full hemitransfixian incision, and we have an extended hemitransfixian incision. So let's look at the left-sided image over here. The partial incision, this portion is the partial incision. Partial hemitransfixian incision is a limited hemitransfixian incision, which is done only when access to septum, posterior septum is not required. So just this amount of incision is enough. Second is the full hemitransfixian incision. So the full hemitransfixian incision is still like almost here. This is the incision which is extended along the entire caudal margin of the septal cartilage so as to allow complete access to the L strut, including the caudal septum. And third, we have the extended hemitransfixian incision, where the incision is extended further along the nasal floor, towards the nasal floor. And this is done when we need to get access to the floor of the nasal cavity. And so this is about the hemitransfixian incision. Then we also have a transfixian incision, which is basically the same incision as the Freer's incision that we were talking about, but here the incision is made on both sides of the caudal septum, separating it from the columella. And this incision is typically used for septorhinoplasty and in caudal dislocation. So these are the three different incisions that you need to know. The more commonly viva questions that are asked in, especially in UG, would be just to know what is Killian's incision and what is Freer's incision. And you do not need to know all these different types of hemitransfixian incision. But from postgraduate standard, you should be knowing all of these different incisions. So that's about the septal incisions, septoplasty incisions. Now we'll talk about the different steps of septoplasty. So, about steps of septoplasty. Now, whenever when you are asked about what are the steps of septoplasty, always start not directly from, oh, we'll give this incision and we'll do, when we'll proceed with the different steps. You should start from anesthesia. So first we'll talk about what anesthesia do we give. So usually in septoplasty, local anesthesia is preferred, but we can also use general anesthesia, especially in children or in apprehensive adults. And even in general anesthesia, if we are doing this, we will prefer a hypotensive anesthesia. Next, we'll talk about the position of the patient. So let's look at the position over here. Here we'll have the patient in a supine position, but with a 15-degree head end elevation. Now, what is the advantage of doing this position? We have three reasons over here. First of all, this head end elevation, it will reduce the venous pressure in the head and neck region. Secondly, as a result of this, this will also reduce the intraoperative bleeding that you'll get. And as a result of this, you have a good surgical field visibility during the time of surgery. So these are the three reasons why we should have the patient in this 15-degree head end elevation. Next, after the position is done, next is we have to infiltrate. So if we mostly, since we do by local anesthesia, we will go by local infiltration. Now we will infiltrate both sides of the nasal septum with 1% lignocaine with 1 in 1 lakh adrenaline. Now, what is the reason why we give this adrenaline? First of all is that the adrenaline will cause vasoconstriction, as a result of which you will have less bleeding during the time of surgery. So that is the reason why we give adrenaline. And second thing is, this infiltration that you're doing, what is the plane at which that you give this infiltration? We will give this infiltration at the mucoperichondrial and mucoperiosteal plane. This plane is the plane that you give infiltration at, so that the flap elevation becomes easier if you have infiltrated correctly in this plane. And how will you know that the correct infiltration has been done, correct plane? You will see when you infiltrate that there will be blanching of the nasal mucosa. So this is why you should be infiltrating in this particular plane. Your flap elevation later in the surgery will become much easier. So now that we have infiltrated, our next step is to give a incision. Now in septoplasty, we usually use the Freer's incision or the hemitransfixion incision, which is given at the caudal edge of the septal cartilage on one side only, and usually we give this on the concave side of the deviated septum. So if the septum is deviated to the right side, we will give the incision on the left side. Now, after we have given the incision, our next step is to raise mucoperichondrial flap on the concave side. Now, mucoperichondrial flap is raised only on one side in septoplasty. This is important to remember here. In SMR, usually flaps were raised on both sides. But in this case, we raise flap only on the concave side. Why is it done only on one side? This is to ensure that the viability of the cartilage is maintained. So if you end up elevating on both sides, there are more chances of injury to the mucosa. Second is, this will also reduce the chances of developing any septal perforation or septal abscess or hematoma. So we are basically trying to preserve the flap on one of the sides and raising the mucoperichondrial flap on concave side. Now let's try to understand that what is the plane at which we are raising this flap. So if we look at it, let's look at this image over here. We have the cartilage or the bone. On top of the cartilage, we have a layer of perichondrium, and on top of the bone, we have a layer of periosteum. And then on top of this perichondrium and periosteum, we have the nasal mucosa, which we are able to touch. When you put your finger in the nose, you're able to touch the nasal mucosa. So in between the cartilage and perichondrium is where we are trying to raise the flap. So we are trying to raise this mucoperichondrial flap. So if we look at the images over here, this is the septal bone, and this is the septal cartilage, and this is the maxillary crest over here. So when we raise the flap, this is the concave side. After raising the flap, this is what it will look like. We have raised the mucoperichondrial flap over here. So after raising mucoperichondrial flap on one side, our next step is to do a bony cartilaginous disjunction. So this here is the septal cartilage, and this is the bony cartilaginous disjunction junction that we are seeing. So we have to remove disarticulate this junction so that we can gain access to the opposite side of the septum. So we perform a bony cartilaginous disjunction. After performing this, now we have access to the other side of the septum. So here now we raise the mucoperiosteial flap. So here we have raised the mucoperichondrial flap. Now we will be raising mucoperiosteial flaps on both sides of the bony septum. And also we will raise the flap from the maxillary crest in the floor as well. After all the flaps have been raised, our next step over here is to identify the deviated part of the septum, and then we'll remove whatever deviation is present. We'll remove only the deviated part and not any other part. And in septoplasty, we have actually different methods by which we can correct the deformed septal cartilage. One such method is scoring. Scoring, in the first image over here, you can see scoring is basically when we give these slight incisions in the concave side of the deviated septum, which later heals to straighten up the septal cartilage. We can also excise off a part of the septum if required with the help of wedge excision and put it back. In case of caudal dislocation or caudal deviation like this, we can remove a part and then put the septum back into the maxillary crest. So there are different ways by which you can do it. There's scoring, there's cross-hatching, there's wedge excision. All of these are different methods that you use to correct the deformed septal cartilage. Now, once the deviation has been corrected, you replace back the mucoperichondrial and the mucoperiosteial flap, and the incision that you had placed earlier, you close that incision with the help of absorbable sutures. And then we'll pack off both of the nostrils. So now if I had to recap yet again, let's start with anesthesia. First we'll tell the anesthesia, then the position of the patient, then we'll infiltrate the nasal mucosa at the right plane. After that we will give the hemitransfixion or the Freer's incision at the caudal edge of the septum, and then we will raise the mucoperichondrial flap on one side. Next we'll perform the bony cartilaginous disjunction. We'll raise mucoperiosteial flaps on both sides and also from the floor. Then we'll remove the deviated part of the septum and correct it by any method required. We'll reposition the flaps, we'll close the incision, and then we'll pack off the nose. These are the steps of septoplasty that you need to know. Next is, what are the packing materials that you usually use in septoplasty? So earlier we would use medicated ribbon gauze, and it's still used in a lot of places. And the newer edition that is now more common is we use a Merocel. And this pack is usually kept for 24 to 48 hours, after which it is removed. This brings up to the next question, which is, what is the post-operative care that you will give to the patient? So we'll remove this nasal pack usually after 24 hours and then discharge the patient. Start the patient on oral antibiotics, decongestant nasal drops, analgesics, antihistaminics, and follow them up after 1 week. Next is, what are the complications of septoplasty? Now, if we had to discuss the different complications, here we will divide them into intraoperative complications and postoperative complications. And postoperative complications itself can be divided into immediate ones and delayed ones. So under intraoperative complications, first of all, we'll have some anesthetic complications. Anesthetic complications can be because of hypotension or cardiac arrest or any drug allergy that the patient faces. Next is the only other complication that here we'll face is hemorrhage, which is a major one. So that is why it is important that you infiltrate the nose properly. You use adrenaline as well during infiltration, and also the head end elevation during the positioning of the patient will also help make sure that your visibility is better. Next, moving on to the postoperative ones. Now, the immediate postoperative complications can again be hemorrhage. There can be headache. Now, headache can happen because of tight nasal packing. So if you have packed the nose very tightly, that can actually cause headache to the patient. And the second thing that the tight nasal packing can cause is eyelid edema. So this is something that will resolve the moment you remove the pack. Next are the delayed complications. In delayed complications, we have, so if we, let's look at the image over here. I was talking about L strut a little while back. L strut is basically the L-shaped structure that you're seeing over here. L strut is, this part is the caudal strut, and this part is the dorsal strut. Together they form this L-shaped structure. Now this L strut has to be maintained so as to ensure that there is adequate support to the external nose. If this is not maintained, which is exactly what would happen in SMR, we remove a lot of the cartilage. In here, we maintain a 10 millimeter L strut. So this L strut basically helps in maintaining the support to the external nose. Now, say for example, the dorsal end of the strut, this is not maintained as much, and maybe there is not adequate support. In that case, the complication that we can face over here is known as a saddle nose deformity. So if this portion goes down because of support, because of lack of support, if it becomes like this, you can see that this looks like a saddle that is used in when you sit on a horse. So this is known as saddle nose deformity. Second is, if this caudal strut is not mentioned, it can lead to columellar retraction. We can also have supratip depression if excess cartilage is removed in this area. So these are three deformities that can happen as a result of septoplasty, but this is not seen in septoplasty as much. These are more complications that you see in case of SMR. So saddle nose deformity, supratip depression, and columellar retraction. So other than this, let's think of SMR. In SMR, usually a huge portion of the septal cartilage is removed. So essentially, the septum is removed here. So now what you're left with is two mucoperichondrial flaps with no bony support or cartilaginous support in between. So sometimes blood can end up collecting over here, and that can lead to the development of septal hematoma. So that is a delayed complication can happen because of this dead space in between the two mucoperichondrial flaps. This collection can get infected and then form a septal abscess. And this septal abscess, if it continues to exist and it ends up causing necrosis of the mucosal lining, it can lead to the development of septal perforation. So these are all the different delayed complications that you can have in septoplasty, but this is more commonly seen in SMR. Other than this, you can also have synecdoche formation when the mucosa is damaged on both sides, on both the septum side as well as the lateral nasal wall. It can lead to the joining of these two, leading to the formation of a synecdoche. You can also have recurrent or persistent nasal obstruction. And some rarer ones are CSF rhinorrhea and toxic shock syndrome. So these are the different complications of septoplasty that you need to know. Now let's look at some images over here. This is what a nasal synecdoche looks like. You can see that there probably was a raw area of mucosa on both sides and it ended up joining together through this synecdoche. Then this is a case of septal perforation, and this is a case of septal abscess or hematoma. They'll both basically both be looking the same way. There'll be like bilateral swelling on both sides of the septum. But how will you differentiate it? In a case of septal abscess, you will get fever and other systemic signs of infection, whereas in hematoma, you will not have any fever. Next this is what a saddle nose deformity looks like. So I told you, if the dorsal strut gets removed, if there was not enough support at this portion of the nose, then this can sink downwards, and this is what a saddle nose deformity will look like. And if the caudal strut was not enough, then it can lead to columellar retraction. So this is what these are all the complications of septoplasty. Now, what are some causes of saddle nose deformity that you know, other than the one that we already discussed? So the first cause is obviously postoperative, where you see more commonly in SMR than septoplasty. Then it can also be as a result of a post-traumatic cause, septal abscess, septal hematoma, congenital syphilis, sarcoidosis, and Wegener's granulomatosis. So next, this brings us to a very important question which is what is the difference between SMR and septoplasty? Now, septoplasty we have just discussed. Now, if we had to just tell you a little about SMR, in SMR, basically it is a more radical procedure where we remove a big part of the septum, where we remove almost the whole septum with a very minimal support left at the caudal and dorsal strut area. So, if we had to describe both of them and differentiated them, these are the criteria that we'll be talking about. First is principle. So, SMR is a more radical excision, whereas septoplasty is a more conservative correction of the deviated septum. Portion removed. In SMR, we remove a large portion of the cartilage and bone, whereas in septoplasty, we remove only the deviated part of the septum. Even if there is a deformed part, we try to correct it and re-implant it back between the mucoperichondrial or the periosteal flaps. Next point is preservation of the septal framework. So in SMR, the preservation of septal framework is not done well. We only leave behind a 2 to 3 millimeter rim of dorsal and caudal cartilage behind. Whereas in case of septoplasty, we have to preserve the L strut and we have to preserve minimum 10 millimeter of dorsal and caudal strut. Other than this, we also preserve most of the cartilage and the bone. Next is looking at the age. Now, just before this, I would like to say our middle third of the face that develops, it completes its development by about 17 years. So the septal cartilage is a part of this. So since SMR is a very radical procedure where we remove most of the cartilage, it should not be done before the age of 17 years. So therefore, we do not perform SMR before 17 years because otherwise it will end up affecting the development of the face. Whereas septoplasty, since it is a more conservative procedure, can be done at any age. Next is incision. So as we said, SMR is done by the Killian's incision, whereas septoplasty is done by Freer's incision, also known as the hemitransfixion incision. Next is mucoperichondrial and mucoperiosteal flaps. We raise the flaps on both sides for SMR, whereas only on one side for septoplasty. I had mentioned this earlier. Caudal dislocation cannot be corrected by SMR. It can only be corrected by septoplasty. Complications are more in case of SMR because it is a more radical procedure, whereas it is lesser for septoplasty. And rhinoplasty, if say we had to perform rhinoplasty, we cannot combine SMR with rhinoplasty, whereas septoplasty can be combined with rhinoplasty and make it a septorhinoplasty procedure. So these are the differences of septoplasty and SMR that we need to know. Next is coming to, we mostly talked about septoplasty. You will not be asked much about the turbinate surgery. We'll talk a little bit about it though. So what are the different surgeries that you could possibly do to reduce the enlarged turbinate? So we can classify that. So we can classify them into three types. First, we have the mucosal preservation surgery, which is more preferred. Then we have the mucosal destructive reduction surgery and the turbinate excision procedures, which is the more radical ones. So in mucosal preservation surgery, we can lateralize it by outfracturing, or we have mini microdebrider surgery, radiofrequency coablation, turbinoplasty, and submucosal diathermy. Under mucosal destructive reduction surgeries, we have superficial cautery, chemical cautery with chromic acid or trichloric acid, and cryosurgery, laser surgery, and direct microdebrider mucosal reduction. And then under turbinate excision procedures, we have partial turbinectomy, subtotal, and posterior end. So this is the complete list of all surgeries that you can do for enlarged turbinates. The one we usually prefer to do is usually the turbinoplasty, submucosal diathermy. Mostly the mucosal preservation surgery is what is preferred. And last question for today is, what is empty nose syndrome? And this is a complication that you usually feel after turbinate surgery has been done, if the turbinate has been removed excessively. So this is a condition which is characterized by paradoxical nasal obstruction and breathing discomfort following excessive turbinate surgery or turbinate removal. And because of this leads to the loss of normal nasal airflow regulation and sensory feedback. So, despite the space being created in the nose, the patient will complain of paradoxical nasal obstruction. This has happened because there is a loss of physiological airflow resistance, humidification, and warming, which is the normal function of the nose, and trigeminal sensory feedback. Because of all of this, the airflow becomes fast, turbulent, and poorly sensed. That's why the patient feels as if there is a paradoxical nasal obstruction going on. So that's all about our case discussion on deviated nasal septum. Please let me know if you've liked it. If you have any more questions regarding this, please note them down in the comment section and I'll get back to you. Thank you.